So, Bismillahirrahmanirrahim. These are two topics under one talk. So, obesity as a risk factor for coronary artery disease and its emerging management. So, these are two talks, but I'll try to complete these talks in next 12 minutes. So, it is most common preventable disease, and it is a disorder of weight regulatory system. So it's a complex interaction between our hypothalamus, subcutaneous fat, leptins, integralins, and many other factors which characterizes the excess body fat accumulation. It is a growing health problem worldwide. According to WHO, 39% of our population is overweight and 13% out of them are obese, which is a big number. So it has multiple etiologies like biological factors, genetic factors, environmental factors, behavioral factors, how someone approaches towards his meals. Is he more friendly in vegetables and fruits, or is he taking pizzas and burgers? And then the body has got a body set point where it tries to maintain its the weight. So prevalence of obesity is increasing, as we can see in these slides, that in America in 2030 it is almost going to double. Similarly, if we see on the right side of the slide, the obesity in 1975 was far more less, but now it is far more increased. And as you can see that it is more common in females. So how do we assess obesity? Body mass index is very simple, and I encourage that we all should know our body mass index and the body mass index of our patients. Then the waist circumference, it should not be more than 40 in males, and it should not be more than 35 in females. Waist to hip ratio in men should not be more than 1, and in female it should not be more than 0.8. Then we can have visceral adiposity index, anthropometry, skin fold thickness test, and in the research labs we can have CT scan of our fats, MRIs of fats, and DEXA scans. So this is WHO classification of weight status, and this is very simple and very easy. We can calculate our BMI on the basis of our smartphones in 2 minutes, less than 2 minutes rather. So underweight are less than 18.5. Normal range is 18.5 to 24.9. Overweight is 25 to 29.8, 29.9. So we all should be knowing our BMI. Say, for example, my BMI at present is 28. So I am in the category of overweight. Obese is more than 30, grade 1, grade 2, and grade 3. So there is two type of fat distribution: apple-shaped and pear-shaped. Apple-shaped is upper body deposition of fat, and pear-shaped is lower body deposition of fat. So if the fat is deposited below the waistline, it can be taken as okay, but if it is above the baseline, it is bad. So upper body fat increases waist to hip ratio, and it is metabolically more active, and it is the patients are at risk. But lower body fat is okay. They are less at risk. Then there are subcutaneous fats and visceral fats. Subcutaneous fat is metabolically stable, but visceral fat is metabolically active. So to cut it short, visceral and upper body fat is metabolically active. There is increased lipolysis with free fatty acids liberation. Free fatty acids impair insulin signaling, and they are pro-inflammatory. So next 2 or 3 slides, they are very important because they give us the clue that why obesity is a risk factor for ischemic heart disease. So please remember that obesity is a pro-inflammatory or chronic inflammatory condition, and obesity increases free fatty acid levels, and pro-inflammatory cytokines like interleukin-6, tumor necrosing factor alpha, interleukin-12, these reach liver through the portal circulation. In the liver, there is increased secretion of trans-acyl glycerol, which are released as VLDL particles and contribute to hypertriglyceridemia. Then there is chronic inflammation, which leads to insulin resistance, which further increases lipolysis and production of free fatty acids. So now we understand that obesity is not a simple thing. It is, in fact, the adipocytes, they are endocrine cells, which are producing leptins, adiponectins. Leptins and adiponectins, they both make you thin. But in obese patients, either they are deficient or there is less response of individuals to these. So various types of fats. White fat is metabolically active and there is more inflammation. Brown fat we see in infants and young children, and it is stable. And in the lower end of the slide, you can see that as the adipose tissue increases, it increases the biomarkers, inflammatory biomarkers, and then this leads to the problems. So this is the array which the obesity leads us to. And just imagine that if we treat the obesity in our patients, we can treat all these conditions. So obesity leads to mental health problems, cardiovascular problems like atherosclerotic cardiovascular disease, hypertension, atrial fibrillation, heart failure, coagulation disorders, skin disorders, reproductive abnormalities, pulmonary disorders, which is very important. They can have sleep apnea, and then sleep apnea in itself can lead to atherosclerosis. They can have metabolic derangements like type 2 diabetes, fatty liver disease, dyslipidemia, gallstones, and gout. So it's very, very important to treat obesity. With treating obesity, you can treat all these conditions. So this is a busy slide, but this knows that how much work is being done internationally on obesity. So the cardiologist, they must understand the basic pathophysiology of this disease. And there is a paradigm change, and the treatment is now changing towards incretin-based therapies. This is a revolution which we are going to discuss today. So now we come to the treatment plan of obesity. So treatment plan is like diet and poor eating habits, proper eating habits, behavior modifications, exercise, pharmacology, surgery. So these are old generation treatments which we have been using so far, before the revolution which we are going to discuss now. So phentermine, orlistat, lorcaserin, phentermine and combination of topiramate, bupropion, naltrexone. So these were not very optimal in the treatment of obesity. So 2020 was the year in which there was a revolution in the treatment of heart failure. So we had ARNIs, we had SGLT2 inhibitors. ARNIs ने revolutionize कर दी heart failure की treatment को, और इसी तरह SGLT2 inhibitors, they revolutionized the treatment of heart failure in diabetic patients. Now this is the third revolution, which is GLP-1 analogs. And these GLP-1 analogs, they revolutionized the treatment of obesity. And what we are talking about this. So this is a tweet from Elon Musk. We all understand who Elon Musk is. He is one of the richest person in this universe. He is owner of Tesla, owner of SpaceX, and he is also owner of the Twitter now. Before he was the owner of Twitter, he tweeted that he had reduced weight with the help of fasting and Wegovy. And this was a revolution. With that tweet, there were multiple retweets, and it became the top trend in last years. And they found that there were many celebrities who started talking about these drugs, that is Wegovy, Ozempic, and other medications for weight loss. And then this was the talk of the town. This became visible on the social media, this became visible on the print media, and this was also visible on the electronic media. So it was so much discussed that this medication became unavailable in the market in USA. And what is this? This is glucagon-like peptide 1 receptor agonist. So this is incretin family, and incretin family, they are gut peptides or hormones which are secreted by enteroendocrine cells in the gut in response to digested nutrients. When we take meals, these are liberated. So these are GLP-1 analogs or glucagon-like peptide 1 and GIP or gastric inhibitory peptides. So they have receptors all over our body, in the brain, in the heart, liver, GI, pancreas, etc. So what do? GLP-1, they go to the brain, they decrease our appetite, they go to the liver, they decrease gastric emptying, they go to the islet cells of Langerhans, increased insulin production, increased beta cell proliferation, they go to the liver, and there is increased insulin sensitivity and decreased production of glucose, and then they go to the heart, and which is cardioprotection is more, and cardiac output increases. So gastric inhibitory peptides, proximal small intestine liberates them. If we combine GIP and GLP, this is known as twincretin, and twincretin is novel medication, single molecule that activates both GLP-1 and GIP-1 receptors. The two appear to have synergistic effect with increased insulin response together versus each alone. So these are various brands which are available, like liraglutide, semaglutide, dulaglutide, and the last one is tirzepatide. So what is the benefit of GLP-1 agonist? Weight loss. The number one benefit is weight loss. They are basically for the treatment of diabetes, but actually they are more being used for the treatment of weight reduction. Semaglutide, tirzepatide, and dulaglutide. So if we see the treatment of diabetes, the basal bolus insulin, it increases weight. Basal insulin increases weight. Sulfonylureas, they increase weight. Metformin slightly reduces our weight. SGLT2 inhibitors, they reduce our weight. But these are the GLP-1 agonists which reduce our weight tremendously. And these are shown in the trials. It was shown in this STEP trial that in 60 weeks of time, there was around 20% reduction in the weight with the help of semaglutide. And with tirzepatide, there was even more, around 24% of weight loss in 60 weeks time. These have to be given in the form of pen injections like we give insulins. And there are various studies going on, and the various trials are going on, and it has to be gradually escalated in the dose. And there are few side effects like nausea, vomiting, because it reduces the motility of our gut. So patient, they complain of nausea, vomiting, abdominal pain, bloating, GERD, etc., etc. And then very few patients can have pancreatitis, and it should not be given in those patients who have chronic pancreatitis. What happens if we stop these medications? So if we stop these medications, the weight is regained. So these have to be given on the long-term basis. Then there is role of bariatric surgery. Patients can have around 30% weight loss with bariatric surgeries. So to conclude my talk, we all should know our BMI. Obesity is highly prevalent, and it is linked to almost all cardiovascular problems. It is a disease and not simply food or willpower problem. General lifestyle modifications and old generation drugs did not work very well. GLP-1 analogs are rapidly being accepted for the treatment of obesity, and they are FDA approved. Get yourself familiarized with various brands of GLP-1 analogs. Cardiologists will soon be using these weight loss drugs routinely to take care of many cardiovascular problems of their patients, and results of GLP-1 analogs are approximating bariatric surgical results. Thank you very much.